Hello, everybody. This is my new podcast. We have today we are discussing about anemias of diminished erythropoiesis, and today we have a Dr. Anmol Powder. Hello, doctor.
Hello, good evening.
So, Dr. Anmol Powder, I want to start a few things about anemia from you actually. Can you just tell me the anemia that caused by the diminished erythropoiesis? What are the examples of the anemia of diminished erythropoiesis?
Uh, those anemia that are caused due to defective erythropoiesis.
Yeah,
It is actually the erythropoiesis occurs in the bone marrow.
yeah,
So maybe it may be a plastic anemia.
yeah,
Okay.
yeah,
Some maybe other like Fanconi anemia also.
yeah.
Some viral anemias like HIV, hepatitis, and Epstein-Barr virus also can cause defective erythropoiesis
Yeah.
due to that anemia due to defective erythropoiesis.
Yeah.
Other causes can be cerebrosplastic anemia, lead poisoning also,
Yeah.
thalassemia also. These all are the anemia due to defective erythropoiesis.
So you mean I want to conclude in a way like you want to say like diminished erythropoiesis can be occur in the iron deficiency anemia and can be occur in the megaloblastic anemia, can be occur in the anemia of the chronic disease, aplastic anemia, and myeloplastic anemia, and Fanconi anemia. Oh, thank you, doctor. So let's talk about the few things that can increase that help to increase the absorption of iron, and that can decrease the absorption of iron. Can you
Very
just
good question. Very good question. I like to add this. I know the view.
yeah,
Vitamin C increases iron absorption.
yeah,
Okay.
yeah,
Similarly, you know that
citric acid can
citric acid also can increase the iron absorption. Okay.
amino acid can increase.
Sorry, amino acid also can increase. Yeah,
And
amino acid also can increase.
Sugar in diet can increase the iron absorption.
So for the inhibitors of the iron,
Yeah.
I like to say tannins that is present in tea and coffee also.
that decreases.
Carbonates decreases the iron absorption. Oxalates and phosphate also decreases iron.
Thank you, doctor. So let's talk about mechanism of iron absorption. Basically, the iron absorption occur through which receptor, Dr. Anmol? Can you just concisely describe about the receptor that involved with the iron absorption?
We have two sources of the iron, like heme iron and non-heme iron.
Yeah,
Heme iron is directly absorbed to the gut,
yeah,
but non-heme iron should be converted into Fe2 plus form before it is converted, before it is absorbed.
yeah.
So what happens is that Fe3 plus is converted to Fe2 in the presence of HCl.
Means
in
ferrous
the,
form.
Ferrous form in the stomach.
Yeah.
That ferrous form now gets absorbed in the duodenum.
Yeah, through which receptor?
That I know that.
Yeah.
So there are two receptors. One is ferroportin.
Yeah.
Or one is what is metal transporter? What is that name?
Divalent metal transporter. DMT1.
DMT1 is present in the
Got me.
luminal surface.
Yeah.
And hephacidin is present in the other surface.
Yeah, thank
so
you.
once DMT transporter takes the Fe2 plus inside the cell, it is again converted to Fe3 plus by hephacidin.
Yeah.
And in the circulation, it is found again in Fe3 plus.
Oh, thank you.
So what form we eat is the form that is in the circulation.
Okay.
Just absorption needs to be
ferrous form. Okay. So you just told me about there is a divalent metal transporter 1 in the mucosal surface, through which ferrous form is absorbed to the GI through GI tract and enter into the circulation, blood circulation. So can you there is called one name, unique name is called as the heptocorin. Do you think the heptocorin is involved in the absorption of the iron? What do you think?
Heptocorin?
Yeah.
Heptocorin also involved in absorption. I actually don't know the.
Yeah. Heptocorin actually not involved in the absorption of the iron. This is basically involved in the absorption of this vitamin B12. So the thing that involved in the iron metabolism, like you just tell me, is ferritin, ceruloplasmin, and transferrin. These three things are basically involved in the absorption of the iron. So the transferrin receptor 1 iron responsive element is increased in transferrin receptor mRNA concentration and synthesis.
Good.
So ferritin mRNA concentration actually not change in the IDA.
Ferritin mRNA
concentration is not changed, but the thing is that transferrin receptor mRNA concentration is increased, transferrin, but ferritin mRNA concentration is not changed in the idea. This is the molecular level things, so it is not that much important, but it's interesting. So I just want to describe about this. So Dr. Paudel, can you just concisely describe about this laboratory parameters of the iron deficiency anemia? Like,
very good question.
Yeah.
So what happens is, in iron deficiency there is mere iron decrease, mere iron store.
Yeah.
So serum ferritin, which is the storage form of iron, is also decreased.
Yeah.
But total iron binding capacity is increased.
Yeah, one
because
thing.
it is the total iron binding capacity is actually determined by transferrin.
Yeah.
So transferrin saturation is decreased.
Trans-
GIBC is
increased. Okay.
Serum iron total also decrease.
Yeah.
And red cell morphology is actually normal.
Yeah.
But there can be a red cell protoprofile.
Oh, so what about like ferritin is increase or decrease?
Ferritin.
Yeah.
Ferritin, it is always decrease because it is a steroid form of iron. You don't have iron, so it's decrease.
So
but anemia of chronic disease, it increase.
Yeah. So but transferrin saturation. What about transferrin saturation?
Saturation is always decrease. So because there is no iron to saturate the transferrin, so it is decreased.
So means iron by total iron binding capacity is called as a transferrin saturation, which is decreased. Yeah, thank you, doctor. So about the response of the therapy of the iron, what is the initial response of iron?
Serum ferritin.
So in 12 to 24 hours, there is an increase in appetite and subjective improvement is the initial the response of iron therapy. So after 36 to 48 hours, there is a erythroid hyperplasia. After 40 to 72 hours, there is a reticulocytosis. And in 4 to 30 days, there is increase in the hemoglobin level. And in 1 to 3 months, there is a replenation of the storage ferritin. Means it takes to replace the total deficient. It takes around 1 to 3 months for to replace the iron storage, doctor. So doctor, let's talk more about the megaloblastic anemia. So what are the histopathological finding of the megaloblastic anemia, Dr. Paudel?
Actually, histopathological finding of the megaloblastic anemia is actually, it is again the anemia due to decreased hemoglobin synthesis or erythropoiesis.
Yeah.
So what happens actually in megaloblastic anemia is like cell becomes impaired DNA synthesis lead to maturation of the nucleus of the precursor of the bone marrow and delayed maturation of in the cytoplasm.
Yeah.
So there will be RBC macrocyte, big RBC will be there. Neutrophil will be hyper segmented. Yeah. Something like that.
Yeah. Okay. The thing is that you just told me about like hypersegmented neutrophil. That's one good finding. Actually, the typical finding of the megaloblastic anemia. Other thing, like if you look for the blood reticulocyte count, there is decrease in the reticulocyte count. And if you check like bilirubin, there is raise in bilirubin, and there is if clinically examined, there is mild splenomegaly. This is a typical finding, but there could be a mild splenomegaly. So Dr. Paudel, so what are the causes? If you say megaloblastic, there are two entities. Say vitamin B12 deficiency, one is the folic acid. So can you kindly say some examples, like this can lead to the B12 and this can lead to the folic acid deficiency? Some drugs, some pathologies. Can you just explain me few causes?
What are the causes of vitamin B12 deficiency, mean to say?
Yeah.
So one is malabsorption syndrome like Crohn's disease and inflammatory bowel disease also is there.
Yeah.
Then next is that radiation also there.
Yeah.
Radiation and vegetarian also are likely to develop vitamin B12 deficiency.
Yeah.
One fish tapeworm is there, you know that?
The fish tapeworm infestation.
Yeah. Diphenhydramine
Yeah,
also
diphenhydramine.
causes
Yeah,
megaloblastic.
no, you want
Sorry,
B12.
B12
And the
deficiency.
folic acid, what are the like that can cause the folic acid deficiency? Like phenytoin can cause the that folic acid.
Yeah,
Yeah,
polyacid
sometimes this OCP can give
to
this
put like this.
folic acid deficiency. So the common finding in the B12 deficiency and folate deficiency is a increase in
Another drug I like to add folic acid deficiency, methotrexate and TMPSMX.
yeah, methotrexate
Methotrexate and
and
TMPSMX, including folic acid you told, they
yeah.
can cause folate deficiency.
So what could be the common finding in between two these entities?
You want to know that?
Yeah,
Actually, the neurological findings are not common in folate deficiency,
yeah,
are more common in B12 deficiency.
yeah, yeah.
But other findings, hematological findings like you know that like megaloblastic anemia,
Yeah,
segmented neutrophil, you find in both.
yeah. The thing is that just if you look for the serum homocysteine level, both have the increased level of the serum homocysteine level. So, do you know the one special, very beautiful term called as the heptocorin? What is heptocorin, Dr. Powell? Can you just say what is heptocorin?
I actually don't know what is this.
Yeah, it's you know about the salivary protein. You know one thing that is secreted from the saliva.
Oh, vitamin B12 bind to that.
Yeah, that's the actually the heptocorin. So heptocorin is actually bind with the vitamin B12 and that is free in the stomach. After entering the stomach, it will free and then it is bind to the intrinsic factor. So intrinsic factor, after binding the intrinsic factor, it will go to the terminal ileum. Do you know that there is a in terminal
Heptocorin is secreted from saliva.
Yeah.
That binds to vitamin B12.
Yeah.
It is actually protects the B12 from the acid degradation.
Yeah.
And it goes to duodenum.
No, before going to the duodenum, the heptocorin is breakdown. Then B12 is bind to the intrinsic factor. Yeah, then intrinsic factor it carry to the terminal ileum.
Good.
Yeah, terminal ileum, there is one beautiful term. You will just say this, the cubilin. Cubilin. Cubilin is actually the receptor. Receptor in the terminal ileum, in cubilin on the terminal ileum. On cubilin, the vitamin B12 will bound. So carrier protein transcobalamin 2 is after binding that cubilin and this transcobalamin 2 receptor is there that secreted that B12 to the plasma. They process by this process actually the vitamin B12 will absorb. So can you just told me about the like what are the type of this pernicious anemia? Can you just classify simply what could be the different type of the pernicious anemia?
Pernicious anemia is due to deputy intrinsic factor.
Like say you say like antibody actually antibody of the pernicious anemia is there. According to antibody, can you classify the pernicious anemia, Dr. Powell?
Pernicious anemia is for.
So if you like say there are three type of this antibody of the pernicious anemia. There is type 1, type 2 and type 3. Type 1 is basically the antibody blocks to binding vitamin B12 to intrinsic factor. Once the vitamin B12 bind with this heptocorin and it is enter to the stomach. After entering stomach, the intrinsic factor is bind with the vitamin B12. But thing is that if there is antibody is present, that that inhibit the binding of heptocorin. No, B12 with the intrinsic factor. That is the type 1. And type 2 is another that prevents the binding of the vitamin B12 and intrinsic factor to ileal receptor. I just told you about like intrinsic.
What receptor?
Ileal receptor, cubilin. That inhibit the which antibody that inhibit the cubilin binding.
Cubilin is actually the receptor for vitamin B12
in terminal
ileum.
Yeah. So a third type is that recognize actually that inhibit the recognition of the alpha and beta subunit of the gastric proton pump. That is the third type that actually inhibit the gastric proton pump.
Mm.
These are the three type that is antibody related with the pernicious anemia. So can you just just recall me about that most common cause of the aplastic anemia? Can you just tell me, Dr. Powell?
Aplastic.
Yeah,
Aplastic anemia, most common cause.
yeah.
Most common cause of aplastic anemia always Fanconi anemia.
So most common cause of the aplastic is non-A, non-B, non-C hepatitis. This is the most common. Aplastic anemia can transform into the AML and MDS. And the,
Yeah, can transform.
yeah. So most
Very
common,
less, 1%.
yeah. So most common cause of the myelopathic anemia is the metastatic cancer. So basically metastatic like breast, lung and prostate can cause the metastatic cancer. So thank you, Dr. Anmol. By this we just finished our discussion with the Dr. Powell about the some anemia due to the decrease in erythropoiesis. Thank you everybody.